Assalamu alaikum. In today's video we will discuss the upper limb nerve injuries. آخر محاضرة بالupper limb. المطلوب منك بنهاية المحاضرة إنه explain nerve injuries. تعرف تحددها، تعرف تحدد السايت of the injury لكل nerve. بعدين تعرف الeffect مالته اللي راح يطلع على الموتور والsensory function of the upper limb. Second is to identify hand deformity. شنو hand deformity؟ hand deformity هو abnormal posture or abnormal position of the hand إذا نقارنها بالresting position الnormal resting position of the hand اللي درسناها بالمحاضرة السابقة. فكل nerve injury، كل واحد من nerve injuries اللي راح ندرسهم راح يسوي لي specific hand deformity. لازم نعرف يعني من نشوف hand deformity well this is related to this nerve injury. There are two types of injuries involving the brachial plexus. The more common one is the upper brachial plexus injury, which involves the upper C5 and C6 roots. It may also involve the superior trunk of the brachial plexus. The following nerves will be affected due to this injury. Suprascapular nerve, which supplies the supraspinatus and infraspinatus muscles. A musculocutaneous nerve, which supplies the biceps brachii, brachialis, and coracobrachialis muscles, and also continues as a lateral cutaneous nerve of forearm. Axillary nerve supplies deltoid and teres minor muscles, and also continues as a superior lateral cutaneous nerve of arm. So, knowing the function of these nerves will give us an idea about what will the patient suffer when these roots will get injured. The main cause of this injury is due to lateral displacement of head into the opposite side of injury and shoulder depression on the same side of injury. This will lead into over-traction on the upper roots of the brachial plexus. In adults, this occurs due to a fall from height on a laterally bended head and on the shoulder, while in babies usually occurs in newly born ones. This occurs due to dystocia, and dystocia means difficult labor. In this case here we have a shoulder dystocia, in which the shoulder is stuck into the birth canal, resulting in displacement of head by pulling it in trial to deliver the baby. This creating a tension on the upper roots of the brachial plexus and consequently its injury. So, loss of muscle function innervated by C5 and C6 roots will give us a deformity called Erb's palsy. In fact, it's called Erb-Duchenne palsy. In this palsy, we can see that the arm is hanged by the side of the patient, enabling to abduct the shoulder joint. This is due to paralysis of supraspinatus and deltoid muscles, as well as there's a loss of C5 myotome. Secondly, the arm will be medial rotated, and this action is by the unopposed contraction of the pectoralis major muscle. This is due to paralysis of infraspinatus and teres major muscles. There will be a weak shoulder flexion. This is due to paralysis of coracobrachialis and log head of biceps. There will be a weakness or loss of elbow flexion as a result of paralysis of biceps brachii and brachialis muscle. Lastly, the forearm will be pronated as it's shown here. This is due to loss of C6 myotome, which is a myotome responsible for supination, as well as there's a paralysis of biceps brachii, which is the pronator of the forearm. Now, this position of deformity will give us a picture that's resembling a waiter which is asking for a tip. That is why it's called a waiter's tip position. And as we will be expecting, the sensory loss in upper brachial plexus injury will follow a dermatomal arrangement because we have C5 and C6 injury. So there will be a sensory loss in C5 and C6 dermatome. Lower brachial plexus injury affecting lower C8 and T1 roots of the brachial plexus. This will affect the functions of median and ulnar nerve. The main cause for this injury is due to hyperabduction of the arm, and this may result when a person falls from a height and holding an object to save her or his life, or falling an outstretched hand. And this might also occur during birth of baby, when the arm is presented and there will be an over-traction upon the arm. The resulting deformity from C8-T1 roots injury is called Klumpke's paralysis. This deformity occurs due to paralysis of small muscles of the hand, especially interossei and lumbricals. As the ulnar nerve and the median nerve both are affected, so we will get paralysis of all muscles of the hand. As you can see, the hand in this deformity resembling a claw, so that's why we call it claw hand. Here we can see that the metacarpophalangeal joints are hyperextended, while the interphalangeal joints are flexed. These are the opposite actions of the small muscles of the hand. Next slide will explain the function of the small muscles of the hand and how the loss of this function will affect the posture and position of the hand. To better understand the concept of claw hand and how loss of function of the small muscles of the hand can lead to this deformity, we need to review the actions of these muscles. As you already know, that extensor digitorum are the main extensors of the metacarpophalangeal joints. They don't act on the interphalangeal joints. This is due to mechanical limitation opposed by the flexor digitorum profundus and flexor digitorum superficialis. However, the insertions of interossei and lumbricals, the small muscles of the hand, into the dorsal expansion or the extensor hoods, I hope you remember them from the lecture of the hand. These are the aponeurotic expansion on the dorsum of the metacarpophalangeal joints. They send bands into the into the distal and middle phalanges. The insertions of these two muscles into this hood give them the advantage of acting on both the metacarpophalangeal joints and the interphalangeal joints. They can, at the same time, flex the metacarpophalangeal joint and extend the interphalangeal joint. This cannot be done by the extensor digitorum. Extensor digitorum can only extend the metacarpophalangeal joint. The action of these muscles together give us what's called the upstroke position of the hand. When we lose the action of these muscles, we will get the opposite movement of the small muscles of the hand. So what we will get is hyperextended metacarpophalangeal joints and flexed interphalangeal joints. This occurs due to unopposed action of the extensor digitorum. while the flexed interphalangeal joint occurs because of limited length of flexor tendons. We can increase the length of the flexor tendons to hyperextend all the joints of the digits. This can be seen especially in Klumpke's paralysis because of both ulnar and medial nerve injury, affecting all medial four fingers, giving us the appearance of claw hand. Sensory loss in Klumpke's paralysis will also follow the dermatomal distribution and will result in C8-T1 dermatomal loss of sensation. Long thoracic nerve is a pure motor nerve arising from C5, C6, C7 roots. It supplies the serratus anterior muscle. There are many causes to injure the long thoracic nerve. First one is radical mastectomy, which means an extensive removal of breast and underlying muscles and tissues, and this may carry a high risk of long thoracic nerve injury. Thoracic surgery, any surgery on the thoracic cavity, might injure the long thoracic nerve. Penetrating wound along the course of the thoracic nerve may also injure the long thoracic nerve. Insertion of a chest tube, and this is a procedure, this is a chest tube, this is a procedure which carried out in the emergency, usually, the emergency department, where we put a tube into the thoracic cavity for whatever the reason. The insertion point of this tube is usually near the course of the long thoracic nerve. This might result in its injury. The deformity arises from serratus anterior muscle paralysis, is called winging of the scapula, in which the medial border becomes prominent when we ask the patient to push upon the wall. Other function lost is that inability of the patient to abduct his arm beyond 90 degrees. The reason behind that is that serratus anterior is responsible for the lateral rotation of the scapula during shoulder joint abduction, especially beyond 90 degrees. So when we ask the patient to raise hands above his head, he can't do that. The other function that's lost is protraction of the scapula. There are many causes for axillary nerve injury, such as anterior inferior dislocation of the shoulder joint, fracture through the surgical neck of humerus, or misplaced injection into the deltoid muscle. The muscles involved are deltoid and teres minor muscles. Clinical manifestation: there will be loss of abduction from 15 to 90 degrees. This is because the function of deltoid muscle is abduction from 15 to 90 degrees, while the abduction from anatomical position to 15 degrees is a function of the supraspinatus muscle, which is intact in this condition. There will be also a shoulder weakness, and eventually, as the deltoid get atrophied, the more we will lose the rounded contour of the shoulder joint, and the shoulder region becomes flat compared to the healthy side. Sensory loss is a small area of skin over the lower half of deltoid muscle. Radial nerve injury can occur at 3 different sites. It can occur in the axilla, within the spiral groove, or in the proximal end of forearm. Radial nerve injury in axilla can occur due to 2 main causes. It occurs in pressure of badly fitted crutches into the armpit, crutches yani akazat, or falling asleep with arm over the back of the chair. And this usually occurs in drunk people. That's why it's called Saturday night palsy, because Saturday is the night before weekend. Now, motor loss, as we will be expecting that all the branches of the radial nerve will be affected from the axilla downward. So we will have a loss of elbow extension because of paralyzed triceps muscle, loss of wrist extension and digits because all the branches from proximal part of the radial nerve is being lost. Loss of supination because paralyzed supinator muscles. However, we still have supination with flexed elbow, and I think you should know the reason behind this. The deformity in this condition is called wrist drop. When we ask the patient to raise his hand straight with palm downward, the affected wrist will drop. This is because the effect of a gravity on the hand with loss of extension of the posterior compartment of the forearm. We will also lose the extension of the metacarpophalangeal joints, and still we preserve the extension of the interphalangeal joints because of the function of the small muscles of the hand. Eventually we will get a muscle wasting due to what's called disuse atrophy أو ضمور عدم الاستخدام. ضمور عدم الاستخدام العضلة تبدي تضمر ويسموها disuse atrophy. Sensory loss follows the sensory or cutaneous branches of the radial nerve. Just let me delete this. In the arm, we have inferior lateral cutaneous nerve of arm and posterior cutaneous nerve of arm. In the forearm, we have the posterior cutaneous nerve of arm and the dorsal aspect of the hand with the lateral 3.5 fingers on the dorsal aspect up to the nail bed. Radial nerve injury and spiral groove usually occurs after it gives the branches within the spiral groove, which are the branch to the medial head of triceps, to anconeus, and the lower lateral cutaneous nerve of arm and the posterior cutaneous nerve of forearm. Meaning all of these nerves usually are intact in this radial nerve injury. The main causes for this injury are due to fracture of the shaft of the humerus, and this is the most common one. There's improper positioning on the operating table during general surgery, and there's a prolonged application of tourniquet, especially in skinny people. There will be pressure on the radial nerve on the humerus. Motor loss, we will lose the extension of the wrist and extension of the metacarpophalangeal joints of all fingers due to loss of posterior interosseous nerve function. There will be also a deformity of wrist drop, as we've seen in the nerve injury in the axilla. Sensory loss, there will be dorsum of the hand only because we have intact posterior cutaneous nerve of forearm. There will be only sensory loss within the dorsum of the hand and the lateral 3.5 fingers on the dorsal side. Radial nerve injury in the forearm usually occurs due to fracture of proximal end of radius. This affects the posterior interosseous nerve or the deep branch of the radial nerve, paralyzing all the muscles in the extensor compartment of forearm except extensor carpi longus and brachioradialis, because these muscles take innervation before radial nerve division within the cubital fossa. What we will get is loss of metacarpophalangeal joint extension, which is the action of extensor digitorum, weak wrist extension with radial deviation. We don't have wrist drop here because we have intact extensor carpi longus. However, there will be a radial extension or slight abduction when we do wrist extension. Interphalangeal joints can still be extended because this is the main function of small muscles of the hand. On the long run, there will be a muscle wasting of the extensor compartment, as we can see here. Sensory loss, there will be no sensory loss in this condition because the posterior interosseous nerve is a pure motor nerve. Ulnar nerve injury occurs at two levels. At the elbow joint, which is called high lesion, is the most common site of injury. It either occurs due to cubital tunnel syndrome, which there is a compression of ulnar nerve at the osteofibrous tunnel behind the medial epicondyle, resulting from recurrent microtrauma, or due to fracture of medial epicondyle, as you can notice here. Motor loss will be paralysis of all muscles supplied by the ulnar nerve, which are flexor carpi ulnaris, so we will get a weak adduction at the wrist joint. There will be paralysis of medial one half of flexor digitorum profundus. We will get a weak flexion of medial two fingers, the ring and little fingers. There will be a paralysis of hypothenar muscles, loss of function of all interossei and medial two lumbricals of the hand, as well as paralysis of adductor pollicis. As we already discussed before, paralysis of small muscles of the hand will give us a claw hand deformity. And in this condition, as the lumbricals of lateral two fingers, the middle and index finger are intact, so the clawing will be more prominent on the medial two fingers, which are the ring and little finger. To review the features of claw hand, there will be a hyperextension at the metacarpophalangeal joint and flexion at the interphalangeal joint. In this condition, there will be also a hypothenar eminence atrophy and interossei muscles atrophy, especially apparent in the dorsal interossei. As you can see in this picture, there will be a grooving in the dorsum of the hand. Sensory loss is loss of sensation along the cutaneous innervation of the ulnar nerve, which is the palmar 1/3 of the palm of the hand and medial 1/3 of the dorsum of the hand, as well as medial 1.5 fingers, the little, and half of the medial half of the ring finger. Low lesion ulnar nerve injury occurs at the wrist joint, usually due to cutting injury in the wrist joint. Motor loss is paralysis of all small muscles of the hand except the three thinner muscles and the lateral two lumbricals. Again, this deformity due to loss of small muscles of the hand function is claw hand, and because of it is only ulnar nerve, there will be claw hand of the medial two fingers, the ring and the little finger. In this condition, in low lesion, we will get a more severe and more prominent clawing compared to the upper lesion, and we will discuss this in the next slide. Sensory loss only occurs in the palmar aspect of 1/3 of the hand and medial 1.5 fingers. Sensation in the dorsal aspect of the hand and fingers are all intact because the injury occurs distal to the origin of the dorsal cutaneous branch of the ulnar nerve. Claw hand of low lesion of ulnar nerve injury is more severe and more prominent compared to that of high lesion. However, it should be the opposite, because the high lesion will involve all the distal muscles compared to low lesion, which involve the more distal muscles from the lesion. This is called ulnar nerve paradox, مفارقة الألنر نيرف اللي هو عكس المنطق، اللي هو احنا إذا عندنا high lesion لازم عندنا more severe deformity than the low lesion. This occurs because of intact function of the medial half of flexor digitorum profundus, which will create a more tonic tension on the interphalangeal joints compared to that of paralysis of flexor of medial half of flexor digitorum profundus. So, in case of high lesion, we have paralysis of medial half of flexor digitorum profundus. إذا ما عندنا منه tonic tension of flexor digitorum profundus to pull the fingers compared to that of low lesion, in which the medial half of flexor digitorum profundus is intact. So there will be more tension and more tonic tension on the medial two fingers on the interphalangeal joints, making them more flexed, creating more clawing. This is the ulnar nerve paradox. إذا احنا من يجينا سؤال راح نتوقع انه low lesion give us more severe clawing than the high lesion ulnar nerve injury. Another important clinical sign in ulnar nerve injury, whether it is high or low lesion, is called Froment sign, and it is testing the function of the adductor pollicis muscle. It's performed by asking the patient to hold a paper or an object between his thumb and adjacent fingers by only adducting the thumb. When there is ulnar nerve injury and paralysis of adductor pollicis, the patient is doing the following. He will flex the thumb to hold the paper or the object in its place, and this is called positive Froment sign. Other muscles to be tested are the interossei. So asking the patient to spread out his fingers, this is the abduction, and he will fail to do that. He can't spread up his fingers because of paralysis of the interossei muscles. Injury of median nerve at the elbow can usually occur due to supracondylar fracture of the humerus, or it might also occur from a penetrating wound in the cubital fossa. Motor loss, there will be a paralysis of all muscles supplied by the median nerve, starting with flexor compartment of forearm, except the flexor carpi ulnaris and flexor medial half of flexor digitorum profundus. So there will be a loss of pronation. The forearm is fixed at supination. There will be a weak wrist flexion with adduction because the action of flexor carpi ulnaris intact, because it's intact because of ulnar nerve innervation. In the fingers, there will be no flexion of interphalangeal joint of index and middle finger, because the ring and little finger is supplied by flexor digitorum, by the medial half of flexor digitorum profundus. So there will be flexion at the interphalangeal joints of both ring and little finger, but not the index and middle finger. The thumb will lose all movements except extension and adduction. So we will lose flexion, abduction, and apposition. And one of the most important movements of the thumb that we will lose here is thumb apposition, in which we can recognize subjects, we can hold subjects by what's called the pincer position of the hand, that we hold subjects between the thumb and other fingers. The resulting deformity is called ape's hand, ape's قرد. And that's why, because the hand deformity looks like an ape's hand, in which there's a laterally rotated thumb adducted at position. Because there is no abduction, because we've lost the abductors, the abductor longus, the abductor pollicis longus, and the abductor pollicis brevis in the thinner eminence. There will be also wasted thinner eminence. This will give us the appearance of ape's hand. That's why it's called ape's hand deformity. Sensory loss, there will be loss along the lateral side of the palm, especially lateral 2/3 of the palm, and lateral 3.5 fingers. Back to the dorsal aspect along the nail bed. So here's the mechanism of ape's hand deformity formation. Here is the normal hand at rest position. We can see that the thumb is at the ventral aspect of the hand, or at the palmar aspect, because of the action of the abductors of the thumb. When we lose the action or the function of the abductors of the thumb due to median nerve injury, there will be thumb adduction, and it goes back to the dorsal aspect of the hand, which resembles the hand of the ape. Other sign in median nerve injury is called sign of benediction. And benediction يعني مباركة، تصير خاصة بالرهبان أو بالبابا بالبوبس بالديانة المسيحية يسموها benediction hand. هذه it's an active sign. شنو يعني an active sign؟ الape's hand تصير at rest. When the hand is at rest راح يصير عندنا ape's hand. The thumb is laterally rotated, adducted, and there is wasted of thinner eminence. While when we ask the patient to make a fist or flex fingers, we will get this picture of benediction hand or sign of benediction. Here we can see that we can flex the interphalangeal fingers, or sorry, interphalangeal joints of both little and ring fingers, but we cannot flex the lateral 3 fingers because of paralysis of flexor digitorum profundus, the lateral half of flexor digitorum profundus supplied by median nerve, as well as paralysis of flexor pollicis longus and flexor pollicis brevis in the thinner eminence. هذا الفيديو يظهر لنا مريض عنده median nerve injury. وقبل نشغل الفيديو راح نشوف الهاند deformity اللي هي ape's hand deformity. Thumb is adducted, thinner eminence is flattened. بعدين من نشغل الفيديو هنا راح نسأل المريض إنه make a fist أو flex his fingers. فراح يصير التالي اللي نشوفه this is the sign of benediction or Benedict sign. Injury of median nerve at wrist joint usually occurs due to penetrating wound or stabbing wound at the wrist. Motor loss, there will be paralysis of thinner muscles and lateral 2 lumbricals, and we will get the ape's hand deformity with intact flexion of fingers as well as flexion of the wrist joint. Sensory loss is same as that of the elbow lesion. Carpal tunnel syndrome is the most common nerve entrapment syndrome in the body. It's caused by compression of median nerve within the carpal tunnel. Any reason that increases the pressure within the carpal tunnel can cause carpal tunnel syndrome. Patient will suffer from a pain and paresthesia, which is a pins and needles pain-like sensation over the palmar aspect of lateral 3.5 fingers and back to the dorsal aspect of the distal part of these fingers, as well as the lateral aspect of the palm, but not the skin over the thinner eminence. Why is that? Because of the palmar cutaneous branch of the median nerve crosses outside the carpal tunnel, so it is not involved in the carpal tunnel syndrome. As the condition progresses, patient will suffer from muscle weakness and weakness, especially weakness of thumb position and holding objects between thumb and fingers. Eventually, patient will have a wasting of thinner eminence. So, this figure explains the area that will be affected by sensory disruption. The orange one will be intact in carpal tunnel syndrome, while the green one will be affected by the pins and needles pain-like sensation. There are two important clinical features to be tested in carpal tunnel syndrome. The first one is called Tunnel's test, in which gentle tapping over the region of flexor retinaculum over the median nerve will produce the symptoms of carpal tunnel syndrome, which are pins and needles like pain over the skin of lateral 3.5 fingers, as well as part of the palm. The other test is called Fallon test, which is reproduction of symptoms of carpal tunnel syndrome when asking the patient to do this movement, which is forced flexion of the wrist. Treatment, of course, first is avoiding any movement of wrist flexion, putting a splint here, especially at night, to prevent wrist flexion, which may aggravate the symptoms of carpal tunnel. There might be local injection of some drugs, and eventually failure of these treatment measures will lead to a surgical treatment in which the median nerve is released from the carpal tunnel. With this we end the upper limb anatomy. اللي عنده سؤال أو استفسار موضوع ما فهمه يعلق بالجوجل كلاس روم حتى من نسوي جوجل ميت نناقش المواضيع اللي ما فاهمها. Thank you very much.